very important to understand hepatorenal syndrome. So if Namrata, if I ask you what is hepatorenal syndrome, tell me three important things that will come to your mind. When I say hepatorenal, what comes to your mind? Nothing. It's not an exam. So what comes to your mind when I just say hepatorenal syndrome? What comes to your mind? Anything. Nothing is right. Nothing is wrong. Whatever you want to say. Tell me three things that you'll talk, three things that you'll say that you feel is the most important three things in hepatitis if somebody asks you.
Like, in spite.
Go ahead. You got a duster?
Tuberculosis with ascites and all that thing, and we have even challenged with albumin till the urine output is not there.
So she says that essentially you are saying that the patient should have cirrhosis and ascites, and then you have given, there was a low urine output, so you gave some fluid or whatever you want to give, albumin or something, but the urine output did not come. So you will call this as hepatorenal syndrome, right? Anybody?
Sir, in hepatorenal syndrome, there is underlying chronic liver disease. First one, second one is there is a kidney are functionally normal. Anatomically kidneys are normal. There should
you say patient should have underlying cirrhosis. Patient should have anatomically kidney should be normal.
Yes.
Then
in spite of stopping diuretic for 2 days, there is still persistence of rise in creatinine.
No urine output.
No
you said
urine
three things. You said cirrhosis. You said that this patient had normal kidneys, and the third part is you said that I stopped the diuretics for 2 days and there was no improvement in urine output. Anything else, Ruchika?
Also, rise in the creat by 3 times in the baseline, which is done within a week. I mean, there's a rise in the creat levels.
Wrong 1.5. Which ways? So what we can understand, to understand the pathophysiology of hepatorenal, okay? So what does hepatorenal syndrome mean? In the first place, you have a hepatic disease. You have to have cirrhosis. Without having cirrhosis, you can't have hepatorenal syndrome. Clear? So you should have cirrhosis that comes in, okay? And then the basic problem is the cirrhosis. What does the cirrhosis do?
Splanchnic vasodilatation.
Exactly. The cirrhosis is responsible for causing splanchnic vasodilatation. Okay, as you all know, ascites is caused because of the fact that there is 3 theories are there in ascites, right? In one theory, we say that the splanchnic circulation has got so much fluid that it cannot accommodate that, so it leaks out. The other is that there is peripheral arterial vasodilatation, and that is why there is increased sodium and water retention that causes the ascites. And third is portal vein thrombosis, which is causing excess transportation of fluid and renal avid sodium and water retention. Right? There are 3 theories for overflow, underfilling, and peripheral arterial vasodilatation. 3 reasons why ascites comes in. Right? Out of that, the one important reason, now we think that it is because of peripheral arterial vasodilatation, vascular vasodilatation that's occurring, which stimulates the renin-angiotensin aldosterone mechanism, which causes water and sodium retention, and that is why these patients develop ascites. This is what we now believe with respect to portal hypertension and ascites. Right? But in hepatorenal syndrome, what do we believe? We believe that there is splanchnic vasodilation. Now, what is the after effect of having splanchnic vasodilation? What will happen in your body when you vasodilate?
Hypotension.
There is a possibility. So, how will you prevent that hypotension? Right.
Renal afferent arterial vasoconstriction.
So there is renin-angiotensin aldosterone which starts off. So what happens? Splanchnic vasodilatation. Body wants to defend mean arterial pressure. And since body wants to defend mean arterial pressure, what are you going to get? You are going to get renin-angiotensin aldosterone mechanism to work. Okay. So renin-angiotensin aldosterone mechanism starts working. Clear? Clear on this till now?
Yes, sir.
So you must understand the pathophysiology very well. They will understand hepatitis without thinking also. Okay, HRS is a place where the liver is a problem, And because the liver is a problem, the liver releases nitric oxide. The liver releases nitric oxide. What does this nitric oxide do? It causes splanchnic vasodilatation. It causes splanchnic vasodilatation. This means to say that the body now will start compensating. Okay, when the body compensates, what does it do? It actually releases renin, angiotensin, aldosterone. This is the compensation. What it does? It actually causes renin, angiotensin. So if you have a patient with liver cirrhosis coming with a low blood pressure, what do you understand?
Splanchnic vasodilatation.
What do you understand? What do you understand? That the compensation is inadequate. That is very important for you to understand. Okay, that is very important for you to understand that if by any chance, if there is a patient of liver cirrhosis that comes to you and the blood pressure is on the lower side, what am I thinking? That the compensation is lost, and this patient has got a very high chance of increased morbidity and mortality. What is that? Clear on this? Understood this much? Very, very important. You understood this? That if the patient is having low blood pressure, it becomes a medical emergency. You've understood now why it becomes medical emergency, right? Because the compensation is lost. So just the disease status may be bad versus there is a superadded infection versus there is superadded hemorrhage versus there is so there is a complicated situation here. See, if you have a patient that is at home, has fallen down, broken his leg, bled, you know it is because of bleeding. I will give the blood, he will become fine. But if you have a patient who comes in an acute stage, and unfortunately we don't have patients that come like this, we have patients who come like this. Patient who comes in to the ICU with a hypotensive stage. At that stage you will not realize whether it is the liver that is decompensated or whether there is a superadded infection that is causing the problem, making this a medical emergency. In short, hepatorenal syndrome or hepatic vasodilatation is very similar to sepsis. So that's why the differentiating factor between both is very blurred. You understand? That's why the entire thinking is let me figure out what is happening. Okay, because if I don't figure out what is happening and I don't treat the cause, I might land up thinking this is liver cirrhosis and the prognosis mortality is very weak. Clear on this? So this is happening. So why are we calling it renal problem? If this is occurring, that the cirrhosis is occurring, there is splanchnic vasodilatation, there is renin, angiotensin, aldosterone mechanism working, then why are we calling it that the hepatorenal syndrome is occurring? Because what occurs surprisingly in the human body when there is a liver issue is that this vasoconstriction occurring maximum in the renal bed. This vasoconstriction is occurring maximum in the renal bed. Okay, so there is vasoconstriction in the renal bed. Clear? Are you clear that there is vasoconstriction in the renal bed? So when there is vasoconstriction in the renal bed, there is less blood going to the kidney. When there is less blood going to the kidney, this is what is it called, a renal, pre-renal or post-renal?
Pre-renal.
Pre-renal. So now you have a pre-renal problem coming up. You understand? So a patient of hepatic cirrhosis who has splanchnic vasodilatation has got peripheral renal vasoconstriction. Which causes this patient to have actually pre-renal failure. That's why you talked about all these diagnoses. Ki by pre-renal, what is the treatment of pre-renal? Giving fluid, removing the diuretic. That is usual, no? इसके लिए मेरे को first year MBBS भी नहीं जरूरत है. My mommy will tell me this, that if you are not drinking adequate water, your urine will reduce, isn't it? So it's obvious that if there is pre-renal situation, I am going to give more fluid. Clear? Till now is everything clear? So this now explains to you a laboratory now. This explains to you a laboratory. So what will be your urine laboratory here? It will not show signs of acute tubular necrosis. Like for example, the urine will be routine microscopy will be normal. You will not have casts and necrosis related cells and all these things. You have sediments and all. You will not have all those things because urine is clear. No, there is no protein, there is no blood. ATM में क्या होता है? Because there is necrosis of that glomeruli, there is necrosis of the renal system, acute tubular necrosis. there is going to be the urine that is going to have blood, there is going to have the urine that is going to have protein, because it's dying, no? The kidneys are dying. Are you understanding? You understanding? So you're getting all those things inside the situation. So the urine, if the urine here now shows you that this patient has got blood or this patient has got protein, you have gone beyond the phase of hepatorenal, pre-renal situation to a acute tubular necrosis. Eventually this patient will progress to ATM. Our entire attempt is to prevent this progress. You are understanding this? Our entire attempt is to prevent this progress. Clear? Am I clear on this? Because you must understand that dialysis is not the answer here. You go to dialyze what is already there. Splanchnic vasodilatation. You take out blood, what is going to happen?
More hypotension, more worsening.
More problems, multi-system organ insufficiency, cardiac insufficiency, respiratory insufficiency, acidotic overload, ischemia, brain perfusion coming down, everything will occur. So dialysis is not the answer in hepatorenal syndrome. Okay, ऐसा बोलेंगे कि यार ठीक है यार उसको यूरिन dialysis कर दो. That's why dialysis becomes extremely tough and cumbersome, difficult to do in these patients. You can't do it only. You end up doing CRRT in these patients. You end up doing CRRT and you know this is temporalizing measure because the problem is not the kidney. The problem is what?
Liver.
Are you understanding? So if the hepatorenal syndrome, if the patient goes into hepatorenal syndrome, you can understand the prognosis, mortality is very, very poor prognosis and very high mortality. Clear on this? Because compensation is lost. That is a basic issue. Compensation is lost. Clear? Any doubts till now? Any doubts? So I'll repeat this one more time. Pathophysiology. Okay, you have cirrhosis from whatever origin it may be. This cirrhosis causes splanchnic vasodilatation, which is the sine qua non of liver disease. Okay, and this splanchnic vasodilation causes a compensatory response from the body, which is called as renin-angiotensin-aldosterone mechanism, basically to ensure that there is more amount of water inside. What does the renin-angiotensin-aldosterone do? It actually picks up sodium, picks up water. Okay, picks up sodium, picks up water, so that it fills the circulation because it's dilated. It wants to fill the circulation. Okay, so it does that. When the compensation is lost, patient's blood pressure goes down. But we are not in that stage now. We are in a stage that says cirrhosis occurring chronically, and then one fine day the body gives up, and says I don't want to compensate anymore. And when it doesn't want to compensate anymore, it goes down. That is what normally occurs. But otherwise, in these cases, if the compensation that is occurring is so excessive and it causes splanchnic, it is actually trying to vasoconstrict. However, the renal vasoconstriction is more than otherwise in these patients. And the renal vasoconstriction causes pre-renal failure. It is this pre-renal failure that causes hepatorenal syndrome. Clear? This means to say, if I take the kidney of this patient, even if there is no urine output, and I transplant it to a person who requires a kidney, the kidney will start working. Because the kidney is normal otherwise. You do a biopsy, kidney is normal. Clear? Alright, so now that you've understood this situation, that this patient's kidneys are going down, so what you all said was, I want to diagnose hepatitis. What you said was, okay, this patient has got hepatorenal syndrome, I'm going to give him a fluid challenge and I'm going to try to get the urine out. This works in a ward. This is not work in ICU. Because the patient who comes into the ICU is beyond that phase. You understand? The person who comes into the ICU is beyond that phase. But you are right in talking that to diagnose an hepatorenal syndrome, I need the patient to have cirrhosis with ascites. I need the patient to have we stop the diuretic for 2 days. I need to give him an albumin load of 1 gram per kilogram. 1 gram per kilogram albumin load I want to give. Okay, I want to give albumin load for 1 gram per kilogram. I can't even overgive that fluid. Doesn't make sense only. Okay, 1 gram per kilogram. I want to give that much amount of fluid. I want to see whether the urine output is coming or not. But 48 hours. This occurs over a period of 48 hours. And especially you are diagnosing this condition when the creatinine has gone to more than 1.5 times in 1 week or 0.3 milligrams over 48 hours. So you are not going to see this patient, no? 1.5 times over will less likely. Patient has done one creatinine and 1 week later repeat another creatinine. Then you are not going to see this patient. You're going to see a patient who comes like this to your ICU. A patient who had acute liver failure, who is in front of you with background acute or chronic liver disease, okay, whose creatinine yesterday was 0.7 and today it has become 1.1. Right? Still within normal limits. But what has happened? He has gone into renal insufficiency because it has risen within 48 hours to more than 0.3 milligrams. Clear? It is essential for you to understand that the creatinine does not require a massive rise as you look into renal failure. This is because these patients, these liver patients, have got a creatinine secretory action. Creatinine is taken out of the body. Urinary creatinine is very high. They keep on removing creatinine from their body. The second thing is because of the way they are, they've got extremely low muscle mass. Extremely low muscle mass. That's why I do the muscle mass to understand the muscle mass. Creatinine for him that 1 milligram is also high. So for a cirrhotic patient, 1 milligram per dl of creatinine is also very high. Is also alarmingly high. Are you understanding? Clear on this? So the creatinine becomes a very difficult, kind of laboratory investigation to actually think about renal failure. It becomes a very difficult thing to think. Clear? Right? So we agree to this entire thing that okay, you need to have this, but in the ICU you will not have the time to diagnose it like that. Okay, you will not have the time to diagnose it like that by saying, okay, patient has come in, patient is in hepatic encephalopathy. Let me give him a diuretic-free period. Let me give him albumin for 2 days, and after 48 hours, I will see that the urine is going to improve. You cannot do that. It is not possible. Right? It is not possible because these patients are so encephalopathic, they are so down already, they've lost their compensation. If you give them so much of time, they will probably deteriorate much faster. Clear? So those patients are okay if you are in the ward, okay, or you are at home, something like that, okay, and you just call them for an albumin, and then you see after 2 days what is happening. Are you understanding? But not those patients who are coming to your ICU. In your ICU, these patients are already decompensated. They will come with a history. So the history taking becomes very important here. That is why the history taking becomes very important here. Because you cannot do the challenge to diagnose pre-renal, you have to take an adequate history that takes out pre-renal from your history. You are understanding? The history should be. You are understanding what I am saying? Sachin, you understood or no? अभी हम लोग कैसे diagnose कर रहे हैं patient को? The initial diagnosis that everyone said combined was what we will do. We will give albumin. We will remove diuretic. We will avoid nephrotoxic agents like ACE inhibitors and NSAIDs. Okay, and after that fluid for 2 days, we will watch whether the urine output improves. If the urine output improves, this is not hepatorenal. It is pre-renal. If it doesn't improve, this is hepatorenal. This is what we are going to think. Isn't it? However, in ICU we don't have that kind of time. So now we need to figure out whether this is pre-renal. We don't want to do this test. So I need the history to be very sound and adequate. So what should the history involve? The history should involve whether suddenly there has been a medicine change. Has there been a medicine change anywhere? Okay, that has caused some decompensation. For example, person has been started on an increased dose of propranolol. Okay, or if this patient was on a long, because they are on propranolol because of the fact that they want the heart rate to be low, because we know variceal bleeding reduces when the heart rate is on the lower side. Now, if there is a change in the medications, for example, propranolol, or this patient has received a non-steroidal anti-inflammatory drug in the recent past, or the patient was on long-term midodrine which has suddenly been stopped. Some patients, because of splanchnic vasodilatation, there is a move to keep midodrine 10 milligrams 3 times a day. Okay, midodrine 10 milligrams 3 times a day, that's got wrong. 10 milligrams 3 times a day for long time because of the fact that they are not transplant candidates. So they are given 10 milligrams 3 times a day of midodrine. Now, tomorrow for some reason, patient goes to the medical store, doesn't get that, doesn't take it. So medication error. comes in, which causes this patient to go into this kind of condition. So that one history will become, all these histories, medications become very important. The second history that comes very important in these cases is whether there has been a sudden change in the use of alcohol or there has, because alcohol will cause diuresis. Diuresis will cause the patient to be hypovolemic. Hypovolemic causes other problems that comes in. Third thing, whereas there be altered bowel habits like a fluid losing enteropathy, lose a lot of fluid, lost a lot of diarrhea, dysentery, something like that has occurred which has gone to this situation. Are you understanding? Or there has been an increased use of diuretics. Okay, somebody has stepped up the diuretics because they were trying to manage this patient's ascites. Okay, since that has occurred, somebody stepped up the diuretics. Ideally, a patient of ascites needs to lose a gram, if his edema and ascites 1 gram per week, 1 kilogram per week. Ideally, a patient of ascites needs to lose 1 kilogram per week. So if there is a patient, these patients are chronically managed by gastroenterologists outside. Okay, and then they call up and they say to the gastroenterologist, sir, मेरा 1 किलो बढ़ गया. अभी 1 किलो बढ़ा, क्या बढ़ा? पानी बढ़ा है ना? It is going to be water. So what does a gastroenterologist say? Oh no, you step up your diuretic. Okay, now they step up the diuretic, and what happens is there is huge amount of water loss that can precipitate this patient into hepatorenal syndrome. Clear? So you can talk about the diagnosis like the way you talked about, but it is very difficult to diagnose. So in medical school we learned about fraction excision of sodium and fraction excision of urea. If you remember, Fe sodium and Fe uric acid, these are all not proven in hepatorenal syndrome. We used to use Fe urea and Fe sodium to diagnose acute renal failure from ATN, isn't it? We used to do that. We can't do that here. We used to do urinary sodium. Urinary sodium being less than 20 goes in favor of pre-renal. We can't do that here. Because here there is patient on Lasix, patient on lacilactone, patient is already having excess renin, angiotensin, aldosterone. So sodium is changing because of all these things, not because patient has not had water. You understand? Today, if I don't have water for the whole day, and tomorrow also I don't have water, third day also I don't have water, and third day I check my urine sodium, it will be low because I am dehydrated now. I run a marathon, I came back, your sodium is going to be low because I am dehydrated. But that is not the case with these cases because here everything getting altered because of renin, angiotensin, aldosterone mechanism. Sodium retention, all that is occurring because of this. You understand? So we can't really use, that is why you can't use the laboratory. You can't use the laboratory in these cases. Are you understanding? It has to be a clinical call that you're going to take. There are two types of hepatorenal syndrome. One that is very acute and one that is chronic. धीरे रिवर डिकम्पेंसेट हो गया, फिर किडनी बराबर नहीं हो रहा है, काफी दिन से यूरिन थोड़ा कम है. That is type 2 and there is type 1. Okay, type 1 is the one that occurs acutely. Clear? So now, how do we, now that we know the laboratory is not going to be very significant for us, now that we know that overall this patient's kidneys are normal, how do we treat these patients? So initially, yes, we know that we need to give some amount of albumin, but you don't target a 3 gram. You don't say that I'm going to give albumin to increase my albumin to more than 3 grams. These patients are going to have low albumin. But I don't keep giving albumin to keep the albumin more than 3 grams. I'm giving the albumin to just fill up the circulation a little bit. So the entire thinking is, let us give 1 gram per kilogram at least for 2 to 3 days. How much?
1 gram per kg.
So is a 100 ml albumin adequate? So when I say 1 gram per kilogram, where am I at? Say for a 60 kilogram is 60 grams. 20 grams is there in 100 ml. So at least 100 ml.
3
TDS. It's important for you to know this because the patient down there, it was once a day.
OD.
Then I changed it to PD. I changed it to PD the next day. So you understand this? The dose is generally on the higher side. You want to give a gram a kilogram. Okay, 1 gram a kilogram, which is different from the dose for spontaneous bacterial peritonitis. Okay, this is different from the dose of spontaneous bacterial peritonitis. What is the dose in SBP?
1.5 gram per kg on day 1 and day 3 में 1 gram per kg.
So that's the dose. So in spontaneous bacterial peritonitis it is 1.5 gram per kilogram and day 3 it is 1 gram per kilogram. Correct. Okay. So the dose is different. So here I giving for 2 days. Now what are we giving the albumin for? Reason क्या है? Why do you want to give this albumin? What do you think you want to give as albumin? I said albumin is not for increasing albumin. So
See the response, whether
it's not for that also. No, it's not, because it's not for that. No, because we just discussed that we are not doing that. Okay, so because it will take 48 hours and all these things. Why are we taking albumin? There are a lot of proposed benefits of albumin. There are a lot of proposed benefits of albumin, which actually includes that the albumin may serve as a sink to take up the free radicals. The albumin may coat the endothelial glycocalyx. The albumin may probably increase the colloid osmotic pressure. Albumin may reduce the nitric oxide release. There are many benefits of albumin, and that is why the proposed benefits of albumin are being used here. Clear? Albumin. There are many proposed benefits of albumin that are being used in this for spontaneous bacterial peritonitis. But otherwise, if you think you are going to resuscitate, you will not give just 100 ml. No? You understand? There are other benefits. If it was just resuscitation, why would I give albumin? I would have given crystalloid. I would have just given colloid. Understanding? Because if it was just resuscitation or increasing fluid, I'd just give normal saline. Why do you give such an expensive product? What is known is that when you give albumin, there are other reasons that benefit these patients. That's why albumin is given as therapy, not given as resuscitation. Got the point? Because if it was given as resuscitation, I would rather give fluids. It's the same. We discussed that many times. Understanding? So albumin is given as therapy, right? So that brings a very important question: what do we do with the fluids? This is an extremely difficult task. What to do with the fluids? It's not easy at all to understand whether what to do with the fluids here, and you should be a very good clinical judgment to actually give or not give fluids. The entire thing is a very, very strong clinical judgment. You should be touching, you should be feeling, you should be looking at a history. Everything together should go together. The ultrasounds, everything should go together to actually diagnose whether I want to give the fluid or not. I can't decide by looking at one investigation. Now with this patient, for example, you have a classical case of patient having 5-6 episodes of diarrhea, 10 episodes of loose motions that has occurred, and then patient's blood pressure is slightly on the lower side. Here I know that this patient is probably going to be dehydrated, right? And then I will check for fluid responsiveness with whatever technique I have, because it is not necessary that this patient will respond to the fluid even though he is hypovolemic. I will check for fluid responsive. You're understanding, right? There's a difference between hypovolemia, fluid giving, and fluid responsiveness. Fluid responsiveness means if I give 100 ml, the heart will pump out 100 ml. That is fluid responsiveness. Every patient need not be fluid responsive, even if he is hypovolemic. Are you understanding? The classical example is the lady down there. We are plasmapheresing her, but she's not fluid responsive. You give the fluid, she goes into failure. Classical example, no, that is. You are classically removing fluid. You are every day removing 2 liters plasmapheresis. But you are giving plasma, what's happening? So this means what? Even though you have hypovolemia, she is not fluid responsive. Are you understanding? She is not fluid responsive. So it's not this way blanket statement: patient has diarrhea, let me give some fluid. No. If the patient has diarrhea, will the heart take the fluid? That's the question that I must answer. Okay, will the heart take the fluid? Will the heart pump out that fluid? And that you will get only by understanding, by finding out, by you doing a passive leg raise, or by giving small amount of fluid and checking for aortic flow velocity across the aortic valve, or by giving the fluid and again examining this patient for further signs of deterioration with respect to B-lines, ultrasounds and things like that. Are you understanding? So that is going to occur only if you were to you would be very careful. So the fluid management becomes a big problem over here. Clear? The second thing that comes in hepatorenal syndrome is what do I do now? What is my basic problem? My basic problem is, so what is my ultimate point? I want to vasoconstrict this as much as possible. Right? So how do I vasoconstrict this? So there are 3 drugs that I would probably think if I think of vasoconstriction. One thing is I would think about is terlipressin. Simple, terlipressin. So 1 gram 4 times a day is a dose of terlipressin. Expensive drug. It's not even available in the United States. This drug is not even available in the United States. Okay, 1 gram 4 times a day is a dose you normally want to give these patients. So now you tell me on the background, if you have a patient who is acutely decompensated to you, would you now wait by saying, no, let me wait for 48 hours, let me stop the diuretic, let me give albumin? You will not do that, right? what you will do? You will immediately start this patient on clear, huh? Because my pathophysiology is what? This patient has gone beyond. You understand? This patient has gone beyond. Irrespective of that, even if the patient was pre-renal, you would want to increase splanchnic vasoconstriction. Even if the patient has renal failure, you will still want to increase splanchnic vasoconstriction. So I want to give the NORAD. It is not a bad thing to give NORAD, and I have given at that time, isn't it? Even if the patient was pre-renal nature. You understand? Huh? That is why vasopressin holds a slightly upper hand here. Why vasopressin holds a slightly upper hand? Because vasopressin causes renal vasodilatation. Vasopressin causes renal vasodilatation. Though it has not been proven in real evidence-based medicines, but we know that in septic shock resuscitation, when we add vasopressin, the incidence of having dialysis is less. We know that. In septic shock resuscitation or in sepsis, when we add vasopressin to your existing inotropes, there is not excessive use of dialysis. Clear? So that means vasopressin seems to have a better this over here, but the inotrope really doesn't make a difference in, it has not been studied in this, so you may use noradrenaline also. How much noradrenaline do you want to give? You want to give noradrenaline because you want to raise the MAP by 10 to 15%. I want to raise the MAP by 10 to 15% because if I am not just going to start noradrenaline blindly, just because there is marked hypertension, I want to raise my mean arterial pressure to more than 10 to 15%. Very important. Okay, my MAP has to go up by 10 to 15%. Okay, clear? So culture, which is the other vasopressor you know of? You just finished that. That's why you're sleeping. Get up. Okay. So you know what Rohit you should do? Actually, you will stand in the corner. Let's not go and have coffee. Go. So what was what? So now that we know this, to go have a tea. Go. So what will you get? So after vasopressin, noradrenaline, which is earlier we talked about this. Then one more thing is that we just not talked about it. We talked about midodrine, isn't it? We talked about midodrine. So it is proven to be inferior. Midodrine is proven to be inferior as compared to noradrenaline and vasopressin. It is proven to be inferior. And when you give midodrine, say somebody decides to give midodrine, you never give midodrine on its own. You give midodrine in combination with octreotide. Okay, you never give midodrine on its own, you give midodrine in combination with octreotide. Okay, so usually the dose is 10 milligrams of midodrine 3 times a day and octreotide 200 microgram 3 times a day. Clear? That is usually the dose. Okay, you may give midodrine 6 times also, 4 times a day also. Okay, midodrine can be given 4 times a day, but octreotide will be 200 micrograms 3 times a day. However, what is this? This is inferior as compared to noradrenaline, vasopressin and terlipressin. It is inferior. Clear? Any questions here? So this comes to a very important point. One of the reasons that your cirrhosis patient goes into hepatorenal syndrome is your aggressive ascites tapping. Because what will happen in aggressive ascites tapping? What can occur? When you remove large amount of ascites, there can be hemodynamic embarrassment, sudden hemodynamic embarrassment that can occur. Okay, this sudden hemodynamic embarrassment is going to cause hypotension, is going to cause failure, is going to cause other problems, which will now cause pre-renal failure, which is sine qua non of hepatorenal. Already on the background of patient having renal insufficiency, you are doing an ascites tapping, and that ascites tapping can relate to more renal problems and thus hepatorenal syndrome. Clear? So treating the ascites fluid, ascitic tap properly is very, 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 very important. Clear? You cannot just think, okay, I am going to tap my ascitic fluid. So, so now when you say ascitic fluid, okay, we just discussed. So we've just completed hepatorenal and we're just moving on to the ascites. Okay, in ascites, if we talk about when do you think that this patient needs to be tapped? If a patient comes to you, now the same patient, hepatorenal, comes to you, or this patient of hepatic cirrhosis who's coming to you with decompensation, will you when will you tap these patients?
Suspected subacute bacterial peritonitis.
So how do you suspect that?
Patient is having history of fever, unexplained hypotension.
Only 10% of patients you can suspect clinically. This is very important. So you cannot suspect SBP. You are understanding? How many patients?
10.
This is very important for you to understand. Okay, very important for you to understand. The spontaneous bacterial peritonitis comes with extremely subtle signs. Extremely subtle signs. You may not have fever. You may not have abdominal pain. You may not have anything. Nothing you will have. You will not have anything. So which patients will tap? All patients who comes into the ICU as a result of decompensation of hepatic encephalopathy, you have to tap them. You have to tap them. You understand? Why you want to tap them? Because SVP is a very subtle thing which has to be treated in the first 24 hours. Which has to be treated in the first 24 hours. Clear? Because if it is delayed treatment, it can cause major other problems. Right? What can the problem be? If there is a large amount of ascites, this ascites can go into the lung and cause hepatic empyema. The lung empyema it can cause because this is infected fluid going into the pleural cavity. It can go across, causing empyema. You understand? Clear? So you probably need to tap most of the ascites fluid that is present. So which patient will present to you in which ways? The one who has ascites, the one who has hepatic encephalopathy. These are the patients who will present to you. So it makes a lot of sense to put a needle and tap the fluid if it is tappable. If it is tappable. Clear? Clear on this? And so when I'm tapping, as he said, he was thinking of spontaneous bacterial peritonitis. What am I going to send? So in any ascites fluid, what do I send?
Routine microscopy.
Let me see one by one. Chandrima?
Routine microscopy.
What you said?
Cytology.
You said cytology for what?
We have to find out the number of WBCs and polymorphonuclear.
So you want the number of WBCs?
Yes.
Okay. So what are you going to see with these WBCs?
We have to see whether the polymorphs are greater than 250.
Neutrophils.
Yeah.
Okay. So you're going to look for neutrophils.
Yeah.
So if the neutrophils are more than 250 per cubic millimeter, millimeter cube, we are looking at what?
Yes.
We are looking at spontaneous, so it's neutrophils more than 250. We are looking at spontaneous bacterial peritonitis. So you said you want to send cells, right? What about gram stain?
Yes, sir.
So gram stain doesn't work in these kind of conditions. Only 10% are positive. Okay, so these are important things that you must understand. So I will not get anything on a gram stain here. There's no point of looking into a gram stain here. 10% is nothing. You're not going to get anything. Okay, if you get something, it's very big actually. You're not going to get anything. Clear? So gram stain is something that I'm not really concerned with, frankly, in these cases. Unlike your sputum, unlike your ED secretions, unlike your mini ball, here the gram stain has got much less significance as compared to all these other kind of investigations that we want to do. So in the cytology, what else I want to see? I want to see for malignant cells. I want to see for malignant cells. In the cytology, I want to see for malignant cells. This is something I want to see for. Okay, I want to see for malignant cells in these cases. Then what else you want to send?
Albumin also is important.
You want to send?
Albumin.
So you want to send what? Acidic fluid albumin. So you want to send acidic fluid albumin and serum albumin. Why do you want to do this?
Because we want to find out the
So how do you differentiate that? What is that? How do you do that? How do you calculate it? Ruchika?
Serum ascitic fluid albumin by
Serum albumin minus acidic albumin.
Your exam going. So the answer is serum albumin minus ascites albumin gradient, SAG. Serum albumin minus ascites. It should be at the tip of your tongue because you're doing this day in day out. If you're not doing it properly, that's why you should not pass your exams. Okay? Serum albumin minus ascites fluid albumin. Okay? So these are like basics. If you don't know these, we feel you should not pass because it's something that you're doing daily. If you're not doing it daily, you're not using a head. If you're not doing it on a regular basis, you're not using a head at all, isn't it? So serum albumin minus ascites albumin gradient. Serum albumin, whatever it is, minus ascites fluid albumin gradient is whatever you look at. Here we are not looking at the absolute protein levels and albumin levels. It might not make that difference. In pleural fluid you are looking at that, no? Albumin. You are looking at pleural fluid albumin being 2.5 and things like that. So you are not looking at that. You are looking at serum albumin minus ascites fluid albumin gradient. Right? If it is greater than 1.1, if it is greater than 1.1, is it transudate or exudate? Transudate. It is transudate. Yeah. If it's transudate, you are looking at everything else. Portal hypertension, you are looking at Budd-Chiari syndrome, acute hepatic failure, you are looking at metastasis in the liver, which is causing portal hypertension. But when you are looking at albumin gradient that is less than 1.1, we are looking at peritoneal problems, peritoneal carcinomatosis, peritoneal tuberculosis. You're looking at things like that which is inside the body, inside the peritoneum, right? I'm looking at that. Whereas congestive hepatic failure will not cause transudative ascitic fluid, right? I want to do this. Because I want to know what is happening here. In this situation, it is also very important for you to understand whether it is secondary bacterial peritonitis, which also comes as subtle. When I say secondary bacterial peritonitis, what difference between spontaneous bacterial peritonitis and secondary bacterial peritonitis is what?
Exudative, I guess.
Okay, exudative.
More
You may get bile because it is biliary leak. You may get polymicrobial nature because there is perforation. You may get excess amount of cells, secondary bacterial peritonitis. You may get the pH to be very low. So there are a lot of other things that you may get with secondary bacterial peritonitis. You have to differentiate. Why? Because the treatment is completely different. Here the treatment is what? Operate, seal, do something to that. Whereas the other treatment is what? Give antibiotic, give albumin. Clear? Secondary bacterial peritonitis means some part of the organ has perforated. Cecum has perforated, biliary tract has perforated, something has perforated, which has caused all this to get into the ascitic fluid, secondary bacterial peritonitis. Usually, secondary bacterial peritonitis may have guarding, may have peritoneal signs, may have rigidity. So once you get all these signs, you are going in favor of secondary bacterial peritonitis. Are you understanding? When you're going through all these signs, usually what occurs, you try to do an ascitic fluid tap, you injure a bowel, and then next time you tap again and you get secondary bacterial peritonitis. Clear? Which patient? We had a recent surgery that was operated. That was secondary bacterial peritonitis. Which one? Dr. Prashant Malapatan operated one case.
That was Shivam sir.
Exactly. That was what? Secondary bacterial peritonitis. Can you in that patient with an ascites go and do albumin and all these things? You can't. He operated. Okay. You are understanding? That is secondary bacterial peritonitis. Clear? Secondary bacterial peritonitis. So secondary bacterial peritonitis requires broad spectrum antibiotics, whereas this requires narrow spectrum antibiotics. Because here you are requiring the organism is going to be one single organism.
Equal.
Here you are going to have a large amount of other organisms. Here the organisms are usually gram-positive enterococcus and all these things you basically get. Enterococcus and some you may get some streptococcus, anything you can get over here. Here you can get anything right from Klebsiella to E. coli to everything you can get on the other secondary bacterial peritonitis. Clear? So when I am doing my ascites fluid tapping, what am I going to think when I am doing ascitic fluid tapping? Before I do my ascitic fluid tapping? Now that I know that I am going to tap almost every patient and I want to probably therapeutically do it because it relieves a large amount of stress on this particular patient because he is kind of breathless. I am going to tap my patient, right? So how am I going to tap them? So what is the process for tapping? What is the process for tapping? If I would ask you what is the process for tapping, what investigations you would send and what are you worried about?
It's not perforated.
That's fine. That's the method. Investigations, what will you send? You will send the PT-INR. So what happens with the PT-INR and when do you kind of correct it?
So the PTR, if I tap and the PTR is about to, if there is any bleeding, active bleeding, we have to.
Yeah. So the general consensus. So there is no hard and fast rule, but the general consensus is if the INR is more than 2, you generally tend to give an FFP. Okay, general tendon given effective. Now, why am I saying general consensus? Why not saying like any other tapping? Is because of the fact that these patients have got not only a drop in the coagulation factors, they have also a drop in the anticoagulation factors. So generally, it's a balance. It is a balance between coagulation and anticoagulation. So then generally they don't bleed. Even if the INR is 4, you may end up tapping these patients and they don't bleed. They don't bleed. But generally, the general notion is when your INR is more than 2, I would probably want to tap this patient. I will not give an effect. I will give an effect. Then what else I will want to do in your investigations? Platelets. So platelets, which will prevent you from actually tapping less than 20,000.
20,000.
So if it's less than 20,000, I definitely don't want to tap. This patient is in probable DIC. You are not expecting the patient to have a platelet count of 20,000. 50,000, 60,000, 70,000, 70,000 is okay. But a patient who is in 20,000, this patient is in DIC. Okay, he's in a different condition only. He's probably going to die. Something like that is going on here. Right? So, with a platelet count of 20,000, I'm probably not going to tap this patient unless I give platelets and then I feel it very essential to tap this particular patient. Clear? 20,000 platelet count is kind of a contraindication to tap these patients. Okay? So, when you're tapping these patients, you generally want to tap them. When you're tapping them, you must understand that the amount of fluid is very high. It may be close to 8 liters, 10 liters, 15 liters. It may be as much as that. 8 liters, 10 liters, 15 liters. It may be as much as that. So if you want to tap these patients, which is the approach? Where will you tap them? Where will you tap them? Where is your approach on your body?
Above the midpoint of inguinal.
Sorry?
Above the midpoint of inguinal 2 centimeters.
No. So can you palpate your inguinal ligament anytime? So how can you? Always your landmarks are bony. Always in anything that we do, our landmarks are bony. So which is the bony landmark that you have, Ruchika? What is the position of the tap? It's important. All these things are day in day out things. You cannot not know these things. Okay. So what is the anterior superior left spine? 5 centimeters above the anterior superior left spine and medial to that particular point. 5 centimeters medial to that point. So 5 centimeters up, 5 centimeters medial. Anterior superior left spine, you can do this side or this side. But which is the first side you want to do? Under the umbilicus. 2 centimeters under the umbilicus is the easiest point to tap at. 2 centimeters under the umbilicus on the linea alba. Okay, that is the point where you want to probably tap. Okay, it's easier to tap there. Of course, you have an ultrasound now. With an ultrasound, you can actually see where you are and you can tap properly. But these are the usual points that you want to tap at. Clear? Now, when you are tapping, what are you worried about in these large volume paracentesis?
Decompensation.
Yes, I am worried about decompensation. I am worried about the fact that this patient may decompensate. So, what do I do to prevent this decompensation? So, when do you decide to give albumin?
During transfusion, we can.
So, this is something that we don't know. What we know is that once you tap more than 4 to 5 liters, there is a very high chance of this patient going into circulatory dysfunction. We know this much, that if there is a patient who is going into renal dysfunction, it may occur during, it may occur after, it may occur some hours also. It's not this way that as you are tapping, you keep that fluid. It's not like that. Okay, the body is going to compensate. It's going to take some time to compensate. That is when the problems are going to occur. Okay, so when do you give the fluid? You start thinking of albumin. I will think of giving albumin only when I am thinking of tapping more than 4 liters. Okay, 4 to 5 liters. I will not think otherwise. अगर मेरे को 8 लीटर निकालने I will start thinking. If I am taking 1 liter and 2 liter out, I don't want to give albumin, an expensive product that is not going to help in this particular case, apart from the albumin that I am already giving. See, these patients are already getting albumin 100 ml twice a day. We are talking about that patient that has come into the ICU, where we have anyways given albumin for its other purpose benefits, purported benefits. Now what do you think of albumin? For this paracentesis induced circulatory dysfunction, PPCD, post-paracentesis induced circulatory dysfunction, PPCD. Okay, we are thinking about PPCD here, right? So in these cases, how much albumin I want to give? Let's say for example, I am giving 4 liters of, I am giving 7 liters of ascitic tap. I want to give around 8 grams of albumin per liter of ascitic fluid that I am tapping. How much? 8 grams. So if I am going to tap 6 liters, how much grams I want to give? Approximately 50 grams of albumin. You understand? Because it's 8 gram per liter. If I am tapping 8 liters, कितना हो गया? 48 grams. Huh? 64 grams, sorry, 64 grams. So if I'm making 64 grams, I'll give probably around 70 grams of albumin. 70 grams of albumin is how much amount of albumin? 20, 20, 20 and 10. That is 100, 100, 100 and half. You understand? I will give that much amount of albumin to prevent post-paracentesis circulatory dysfunction. Clear? You can give it during, you can give it after, you can give it wherever you want to give it. Clear? So you are, how much albumin? So first of all, albumin is given only when you have a requirement of tapping to more than 4 to 5 liters of ascitic fluid. And we are trying to prevent an entity called as post-paracentesis circulatory dysfunction. Post-paracentesis circulatory dysfunction is a situation where the patient will drop blood pressure, will become hypotensive. Because of that hypotension, patient will go into renal failure. All these problems are occurring already in a patient who is kind of decompensated. I don't want that to occur. Imagine a patient doesn't come with hepatorenal syndrome, just comes with ascites, you tap him and then you cause hepatorenal syndrome. It can be disastrous. It can be disastrous. It can be one of the most difficult things to occur because we know hepatorenal syndrome, take him out of virus, will become very difficult. Right? So in those patients, if I am thinking more than 4 to 5 liters as a routine, I will give albumin. Understand? As a routine. How much albumin will I give? I will give per liter of ascitic fluid removed, I will give 8 grams of albumin per liter. So if I remove 8 liters of ascitic fluid, I will require to give 8 into 8, that is 64 grams of albumin, approximately 70 grams of albumin. That means 20 grams in 100 ml. So I will have to give 3.5 liters of albumin. 350 ml of albumin.
This is like if I consider downstairs patient, like bed number 3, we are giving albumin twice a day.
That is for what?
That is
hepatic encephalopathy. That's completely different reason.
No, sir. I'm considering like that if patient is receiving routine albumin,
that is different. That is completely different. That is something you don't count that in these.
Okay. So above, if we are removing more than 4 or 5 liter above that, so that twice BD wala albumin.
That is anyways there.
उसके
ऊपर I will give this 350 ml. So if I see a big ascites and I am seeing that this patient is draining and draining and draining, then I know that I'm in the next couple of hours I'm going to drain out another 3 liters. I start the albumin. You understand? Ascitic fluid is not like it's going to drain in 1 minute. It's going to take some hours. So once you have started draining a liter, 2 liters, now you're seeing there's a lot, there's more coming. I see ultrasound, there is lots coming in. What will I do next? I will start the albumin and now I will calculate why I will assume 4 liters nikalne wala hai. So I will anyways give him 8 into 4, that is 32 grams. So 1.5 ml to 1.5 bottles I will anyways give. You are understanding? I will anyways give 1.5 bottles, 20% albumin because it's 8 grams per liter. So वो तो दूंगा ही मैं. And then as it goes higher than that, I will add that 8 grams of albumin more for every liter tapped more than that. You are understanding? Clear? Now, what happens now? You have started this patient, you have tapped this patient. Say for example this was SBP. You have tapped him. You have tapped this patient and you've basically got that the albumins were low, proteins were low, okay, and this is going, but however the patient, and you had some cells and you felt this was SBP, WBC was 300, so you decided to start them on cefotaxime and give him albumin. Now what happens? Now what happens if the ascites doesn't improve? Ascites has to improve, na? SBP तुमने tap तो कर दिया है. Ascites has to improve. If it is not improving, I'll start thinking whether I'm having another pathology. You understand? I'll start thinking whether I'm having another pathology like secondary bacterial peritonitis. You understand? I did an ascitic tap. 2 days or 3 days later, again the patient is feeling. This is secondary bacterial peritonitis. I need to probably look into this to understand what is happening here. This is something different. It's not SBP. So SBP should recover. Once you tap, you give the antibiotic, it should recover because there the problem is different. The problem that the patient is decompensated is because of the infection in that particular ascitic fluid. Clear? Clear? So the crux of all these things is to understand the pathophysiology behind this entire problem. If you understand the pathophysiology that hepatorenal syndrome is splanchnic vasodilatation along with specific renal vasoconstriction, you will avoid the NSAIDs, you will avoid the hypovolemia, you will avoid the nephrotoxic medications, you will avoid the ACE inhibitors, you will ensure that the MAP is more than 15% of what it was, you will give the albumin, you will give the vasoconstrictor, and there is nothing to think about. You know that this is what you are supposed to do. But provided you know this pathophysiology. You understand? I'll send the acidic fluid because I know this can be subtle. A patient coming in with decompensated hepatic cirrhosis, okay, cirrhosis, that is decompensated cirrhosis, there has to be some reason to decompensation. If it is not related to anything else, anyways, there is an acidic fluid, I need to do that because the signs are extremely subtle. That's why I need to do the acidic fluid tapping. That's why even without thinking, what did Abhinav write in the notes? Acidic fluid tap. He wrote that, right? He just wrote that. Why did he write that? Because why did he decompensate? That is the question. So you may want to send urine routine, you may want to send blood culture, you may want to do X-ray chest, you may want to do all these things because subtle signs, these are all very, very subtle in liver cell failure. Small infections can put them into liver cell failure in intrapleural. Clear? Obviously the prognosis is very poor. Obviously the prognosis is extremely poor. Okay? Any questions on hepatorenal syndrome and ascites, parasitis? Any questions here? Probably, because if you strongly believe that we don't have another source of infection, I want to tap it. If I want to tap it, normally want to tap it. But here this patient is very sick, no? This patient is so sick that I know the overall prognosis is poor because he's in DIC probably. The platelet going down, the probable chances is DIC. Okay, you are understanding? And why do you want to do this tap even if the patient has hematemesis? So for example, a patient has come, he's got hematemesis. He's got acidic fluid. Okay, and I know he's hematemesis, the problem is hematemesis. But I still want to tap him. Why do I still want to tap him? Because it might be DIC. It might be spontaneous bacterial peritonitis causing DIC and you are thinking it is esophageal varices. Are you understanding? It could be just DIC. You understand? You cannot find DIC in these patients because INR is anyways going to be elevated. To diagnose DIC in these patients, it becomes alarmingly difficult because the platelets have to be low, the INR has to anyways going to be elevated, the fibrinogen has to be extremely low, it takes a while to get the fibrinogen back. You understand? The conventional definition of DIC becomes a little bit difficult to answer when you have liver cell failure. So I will do it even if the patient has got hepatomesis because there is a possibility that the SBP has caused the infection which has caused this patient to go into DIC which has resulted in hepatomesis. Many times ऐसा होता है ना कि you have a patient has come with hepatomesis and you have done an endoscopy कुछ मिला नहीं, they just had some gastritis which has been, how can that occur? It is because of the DIC.
सर ऐसा भी बोलते हैं ना कि ये हेमेटोमेसिस प्रेसिपिटेट है इज ये एसबीपी नहीं सॉरी ये हेपेटिक एन्केफेलोपैथी
That we discussed, no? That we discussed.
Yeah.
Any hemorrhage, any infection,
Yeah.
any hypovolemia, any dehydration can precipitate hepatic encephalopathy. That we discussed. Here the discussion is not that. The discussion is why should we tap if there is hematomesis?
गॉट इट
We should tap it because first of all we need to diagnose SBP early. We can't say, okay, I did my tapping and the patient I did my endoscopic varices, but the patient has not improved. The patient has not improved probably because he may have SBP to begin with. It may not be hematomesis causing hepatic encephalopathy. It might be SBP causing hepatic encephalopathy. The treatment of which should be initiated early. I can't do it as an afterthought. मैंने अभी एंडोस्कोपी किया, पेशेंट इंप्रूव नहीं हुआ, अरे पेशेंट क्यों नहीं इंप्रूव हो रहा है? You understand? पेशेंट क्यों नहीं इंप्रूव हो रहा है? फिर तूने टैप किया, फिर तुमको पता चला कि एसबीपी है, 4 दिन निकल गया, 5 दिन निकल गया. Now this patient prognosis becomes even more difficult. Clear? But unknowingly, usually normally start the patient on antibiotic, we start the patient on albumin. You are understanding? We start the patient on the treatment for SBP. If you think about it, we normally start the patient on SBP. That is the reason we need to take that. Now, how do you culture this SBP? Very important. The culture. The culture that you send has to be directly inoculated into blood culture bottle. When you take ascites fluid out for SBP, directly take the SBP fluid out and inoculate it into the blood culture bottle. That is the best method to get the best possible specimen that you can get. Clear? Just take the fluid out, sterile technique से insert it into the blood culture bottle like how you take blood culture. ठीक है? That will get your cultures growing much faster than otherwise. ठीक है? Sorry? 8 to 10 ml. उसका वॉल्यूम लिखा रहता है. Open up that blood culture bottle and look at it. उसमें वॉल्यूम लिखा रहता है, 8 ml लिखा रहता है उसमें. Huh? Clear? I think we've done.